Our speaker today is Ashley Collins, who received master's degree from the University of Florida in Speech Language Pathology in 2011. Prior to moving to Ohio, she was certified as a brain injury specialist. Ashley has been practicing in the greater Cincinnati area since 2014. She's certified in Vitalstim therapy, the Mcneill Dysphagia Therapy Protocol, MDTP, LSVT loud treatment, and Speak Out for Parkinson's disorder. She's been with UC Gardner Neuroscience Institute since 2019 in their neurorehab department, in addition to being the primary SLP working with the multidisciplinary Parkinson's disorder clinic. You've probably already read all this. So without further ado, I'll thank Ashley for joining us this morning. I'll thank everybody, and looking forward to this presentation. Ashley, if you'll unmute your mic, you can proceed.
All right. Good morning. Good morning, everyone. Thanks so much for the introduction, Chris. I see a couple of familiar faces. So hello. Yeah, I appreciate the opportunity to come and speak with everyone. I'm going to provide just some information, just the basics of what goes on with dysphagia, some of the things that you can just think about, look out for, as well as some ideas for things to address if you start to see some issues on your own. And then I'll be happy to take any questions at the end if anybody has any. So I think first and foremost, as Chris said, dysphagia is definitely it's a difficulty with swallowing. So it's a change in the mechanics of swallowing, whether it's well, especially in Parkinson's, it's some changes in tongue strength, some changes in initiating the swallow, some discoordination, and it can impact airway safety as well as some airway sensation. So maybe not always feeling, when things are going the wrong way, or even just feeling something kind of in the throat frequently. So most people don't really think about it until it impacts them, but we know that as many as 40 to 90% of people with Parkinson's will experience some kind of difficulty with swallowing at some point in their lifetime. And it's interesting, I think the range there speaks to one of the other symptoms of Parkinson's is sometimes it's harder to pinpoint changes, and because they happen so slowly, oftentimes people don't realize it's an issue until it's kind of reached more of a critical mass point. So some of the studies that are more on that 40% are relying on patient-reported symptoms. So they're like, "Oh, I'm fine," and then you kind of get in there and realize, well, you might be having a few more issues than you realize. So we just know that it's a big impact. So it can really appear any stage of the disease. It's not necessarily linked to the severity, but we do know that it happens more often kind of later. It can happen anytime, but oftentimes you're more likely to experience the further you've gotten into living with Parkinson's. So some of the things we know, the impacts, why are we talking about this? Why do I address this in my clinic? It really comes down to reduced quality of life. There's so much that goes into eating. Again, we don't really think about it until it's impacted, but eating is our meals, our social, right? We grab a cup of coffee or able to eat Thanksgiving dinner, as well as nutrition and hydration is obviously important too. So it can cause isolation, malnutrition, dehydration, and then also the big thing we're always concerned about is something called aspiration, which is just if you inhale food, liquids, saliva, or even stomach acid into the lungs. So I wanted to make sure to include saliva and acid because we talk a lot about aspiration, pneumonia, but it's not just things that are going down or things that you put in your mouth. You can have things going into your lungs that are just your normal secretions, or it can even be, if you have some reflux that's unchecked, things coming back up on you. So big picture, just anything going into the lungs other than air that shouldn't be there. That's where doctors and everybody else start to get a little antsy and nervous. And we do know with that aspiration pneumonia that is the leading cause or pneumonia is the leading cause of death with in people who are living with Parkinson's. So again, that's why we want to address it as soon as we see signs, and there's lots of things that we can do to stave off the impacts for that. So some common signs of dysphagia are coughing and choking during meals. That's more of an obvious one, right? If you notice you or your loved one are doing a lot of coughing while they're eating or drinking, or even directly after, a wet, gurgly voice, especially during or after eating or drinking, drooling, frequent pneumonias or chest infections, feeling as though food is getting stuck, or even taking a long time to complete a meal. I think that goes towards efficiency. Is if you're working just really, really hard to get food down, that can also be a sign that your body's struggling a little bit there. So what can be done about it? Again, I wouldn't be here and I wouldn't have a job if there weren't lots of things we can do to address it. So in regards to coughing and choking on liquids, again, we're concerned about that because it can lead to an aspiration pneumonia or choking. If you're having some weakness and trouble getting things down and feeling like things are sticking in your throat, we want to make sure that you can take food in without it impacting your airway. So the big thing is, that's where I come in, is if those sorts of things are happening, that's where working with a speech therapist can really improve some outcomes. So a lot of times our gold standard is something called an MBSS. It's a swallow study. And what it does is it's a moving x-ray that looks at how food is going through the upper part of your throat. So from your mouth down into your esophagus. And that really tells us, are things getting stuck? Are things just kind of hanging out? Are they going the wrong way and heading towards your airway when they shouldn't be? Along with that is oftentimes we do now also look at the esophagus, since we know that Parkinson's can affect just the way the GI system works and the motility and just cause some, non-specific GI issues. We want to make sure things are going through the esophagus well too. Just looking at big picture. So that's usually the first step, is just identifying the problem, naming the problem, seeing kind of what's going on there. And then from that, yes, a lot of times speech therapists are associated with thickened liquids and changing diets, and that can be a tool. That's one tool in the toolbox, and thankfully more and more, that's not the biggest tool. We try to, as much as possible, avoid doing things like that, especially thickening liquids, unless it's absolutely necessary. Because we know then you can, if there's thickened liquids, it can really contribute to dehydration, right? If it doesn't taste good, or it can also just make it where you don't enjoy what you're eating or drinking as much. So some other things would be smaller bites, and doing kind of softer foods. So some other things is just off the bat, if you're noticing that things are kind of not going down as well or taking longer, add sauces, gravies, condiments, really things to make foods nice and moist. Especially at home, there's lots of things you can do to avoid dry, crumbly pieces, things that tend to get away from you or are harder to chew. So just smaller bites, adding moisture, sauces, gravies, and then even just doing smaller amounts at a time. So smaller, more frequent meals can sometimes combat that fatigue and make sure you're getting enough in without having difficulties. Sometimes even just making some of those adjustments can help deal with it. Sometimes even just some verbal or visual reminders to slow down and take your time. So we know Parkinson's is a spectrum. So some people go too fast, some people go too slow. So if you're on that faster end, or your loved one's on that faster end, even having like a little brightly colored cue card, or having some reminders to slow down, take your time, or presenting smaller amounts of food if things are going too quickly, can help. Another thing that we've seen be effective is, even again for that faster rate, is smaller utensils. So even just using like more utensils that were made for like toddlers, there's a smaller amount, you can't get as much. And then if, on the trimmer side of things, this is kind of getting more into OT land, but they also have, the special utensils that can compensate for a a trimmer to help make sure you're able to get it to your mouth, if that's really the issue. But that's more kind of pre-swallowing. So I think the other thing is to make sure, a good one that we don't often think about is what's going on in the environment. So try to reduce distractions in the environment, whether that's turning off the TV, turning off the radio, or also making sure that you or your loved one are sitting upright as possible versus kind of reclining in a chair when you're eating or drinking. Making sure you're as close to 90 degrees can really also help make sure things are going down well. Another one, pills are notoriously hard for everybody, but something else to consider, even if you're without crushing or opening capsules or making big adjustments to the meds themselves, would be just to put the pills in applesauce, pudding, yogurt, ice cream, just some kind of carrier that can coat it and help it go down a little more smoothly, can make a big difference. And then we always tell people, when you're taking medications, make sure that you drink at least a 4-ounce amount of water to chase it. I know that's sometimes hard if you're just used to taking lots of pills, but that in and of itself can make a big difference because, again, we know sometimes there's some motility issues with the esophagus and getting things down as well. So we want to make sure that you drink enough liquid. And I really tell this to everyone, but especially with Parkinson's as well, that you're drinking enough water to get everything down, and make sure that nothing's kind of sticking. So drink enough water to wash that down appropriately. Okay, some other things that may occur and impact dysphagia and swallowing is taste and preference changes that frequently happen. So may prefer sweets or versus other things. So something we always recommend or look for things like protein ice cream, add protein, peanut butter powder to shakes. And you can hide a lot of nutrition in shakes. I always tell people, if you throw in a banana, if you throw in even some greens, and you add a banana, anything green, a banana usually neutralizes it. So you can sneak in a lot of veggies and some higher nutrients if you do a shake and kind of blend it all up and add a banana. Then all you'll taste is like the fruit or the sweet. So you can still get some of that nutrition in. And then also looking for higher calorie, higher protein items. Look for ways to add healthy fats like avocado. And then, in doing some of those things, all of those are things you can kind of do just on your own. But then we also do say, see a speech therapist, see a nutritionist, ask for a swallow study. Very often I tell people, be a little wary of, just tucking your chin or thickening liquids without having a study to see how it's affecting you. Just a couple weeks ago, I saw someone with Parkinson's who somebody had recommended they thicken their liquids just based off of looking at them, in their home. And then we got them into that X-ray suite, and we saw they were aspirating more with the thickened liquids than with the thin, and they were having a harder time coughing to get it out. So they weren't coughing, but it was because it was just more was going where it shouldn't have gone. So we always try to caution people about doing some of those maneuvers. And even with a chin tuck, if it's more comfortable, if it feels like it's really helping things go down, go for it. But there are certain situations where doing a chin tuck may actually make things head the wrong way easier, especially if there's a lot of weakness and things just sitting in the throat. And when you tuck your chin, it kind of dumps it all forward. So those are all things we're thinking about as we're doing those swallow studies. And that's something we're kind of on a mission to educate in the community too about thickened liquids, is to really only use it when it's necessary. Just because, again, all the different things we listed before, it can impact how much you want to drink, dehydration, as well as just it's not always as enjoyable. I always say, God help the person who wants to thicken my coffee or my wine one day, because we're gonna have a fight. So it's a good tool, but it's one we only need to use when it's absolutely necessary. Some other things that we have in our toolbox, if you were to do some speech therapy, is something called expiratory muscle strength training. And it's actually a tool that was designed specifically to work with people living with Parkinson's. And it's a little device. I actually have a picture of it in the notes that I will give to Chris after this. Some of you may be familiar with it, but it's basically strength training for your lungs. And it's great because it does double duty. So it helps, it helps increase your respiratory support, both for speaking, but we also know that it improves your cough function, and it can also improve the swallowing itself. So almost anybody who comes through my doors with Parkinson's, we go ahead and start doing some of that just to maintain. And if we can improve, because we know it's much easier to maintain function than to try to get it back once it's lost, which we can do, but again, it's just much easier to maintain. And then some exercises. We have some different exercises working on swallowing itself to increase both your efficiency, increase your strength, increase the size of your movements. And that being the idea behind that being, really, we know with Parkinson's, one of the big things it does is just make all movements smaller. So that's why we kind of get mumbly with the talking. The volume gets less. You're not doing as big of breaths, but it also makes the swallowing movements smaller. So that's where you get a little more residue and things sticking around that shouldn't be there. So we do a lot of things involving effort, increased effort. Being intentional. So for those of you that have been through either the LSVTs or speak out programs, a lot of those same concepts apply to swallowing as well, is to really be intentional, be mindful, just be focused on what you're doing and on getting through it successfully. And then I had just a couple other caveats as well here. Something else as far as like the drooling, and that can really go either way. Either sometimes people have excess saliva, or sometimes people have really thick secretions. There's typically those things are more managed medically. So they can be a sign of having some difficulty, but oftentimes it's the medical team that will address that. So with the drooling, there's a couple things going on there. One, we know with Parkinson's, you do less automatic swallowing. So you may just have more saliva building up. So we often say do sugar-free candy, sugar-free gums, just things that try to help stimulate to swallow. And then if there's still just a lot happening there, there's some medications or even Botox that the medical team can do to reduce some of that saliva so it's not as bothersome. And then thick secretions, we always say, really make sure you're drinking plenty of water. Check and then work with your medical team to check for things like postnasal drip, allergies. I know the Ohio Valley is terrible for them. And then also to check for reflux, even if you've never had a history of reflux or you don't experience some heartburn. As I mentioned before, we know the motility of being able to get things down can be impacted just with this condition. And so sometimes people will get what we call silent reflux. And that you can tell if that's happening by seeing an ear, nose, and throat doctor. We can really suspect it based on your symptoms. So some of the symptoms we most often hear and then say, you know what, let's get that checked out with an ENT and look for those signs in your throat would be the thick secretions, lots of coughing at night or first thing in the morning, lots of, thick phlegm. So those are all signs of some reflux, some a little bit of feeling more like your voice is a little hoarse, especially first thing in the morning. Those are all signs that could be happening. And those are easier fixes. So if you're noticing some of those things, chat with your medical team. And then that would just be, medication or lifestyle behavioral things to help. So, and then because again, it's just another little caveat, less to do with swallowing, but something else we always just try to make sure everybody does is to get their hearing checked. But yes, for your loved one, but yes, you too, because we know along with this condition happening kind of later in life, or you may just have, the wear and tear of living on your ears. One of the things that happens with Parkinson's is decreased dopamine, which just Dopamine protects your inner ear from some of that noise-related hearing loss. So when you have less of that in your system, you're more susceptible to faster loss of hearing. So we always just tell everybody, get your ears checked too, not just your loved ones. But maybe that'll also help your loved ones when they're like, my hearing's fine, I just can't hear you. And get you sent over to do some exercises and therapy. All right. So that's it for me. I know that was kind of a lot of information. Does anybody, I was just looking, there's in the chat, it says the candies, do they not also actually create additional salivation? They can, but it also kind of triggers that swallow response. So even though it may increase your salivation, it's also actually reminding your system to swallow. So very often I see people that they're not actually making extra saliva, they're just not swallowing the saliva that they have. So even though it seems counterintuitive, having something there, it kind of like triggers those automatic response systems in your brain to say, hey, swallow, when those just automatic ones aren't occurring as much. So yeah, thanks for that question.
Reminder to everyone that if you do have a question, you can post it in the chat box. And if you're having difficulty finding the chat box, if you will, just raise your hand and we'll recognize you and you can go ahead and ask your question by unmuting your mic. But so any other questions at this point? Go ahead, Frida.
Yes, Jack has been having difficulties with coughing. It started maybe 4 or 5 months ago, and then he has done the swallowing test, and then the doctor has put him on allergy medicine, Zyrtex, and that has lessened the coughing, where it's we're able to use cough syrup and cough drops, but it hasn't gone away. It's diminished till it's doable with. Yeah, substantially, Jack said.
Good.
But, yeah, but my question is. But my question is, do I need to be doing something else, because the swallowing test they did was that it wasn't what they thought from the symptoms of Parkinson, but it would appear to me that the coughing is existing when he doesn't eat, but more so when he does eat, but not necessarily when he drinks. But I think that's just a thing that's going to be there, that it's not going to go away totally.
Yeah, that's where I was trying to say before. I mean, because we don't exist, on our own little speech island. We kind of have to work very closely with all these other disciplines, because there's lots of moving parts and things that can be causing some of these symptoms. So like you said, it sounds like that postnasal drip was definitely impacting as well. Does he have any history of reflux?
No, he doesn't have reflux, but he does have a history of indigestion somewhat, but he has he has a artificial heart. Well, he has a heart valve that was replaced. That's old, and and he had a bypass. So all of these things, I think, are factors.
Absolutely. Yeah, absolutely. And it's not uncommon even after heart surgeries, because the nerve that kind of goes to and supplies your vocal cords goes down around the heart. So sometimes even just your vocal cords themselves, apart from Parkinson's, if you've had heart surgery, can be impacted. So if you haven't seen an ear, nose, and throat doctor ever, or if you have, it might not be a bad idea to do what's called some imaging where they just look at the vocal cords, look at your throat, and see, are there any signs of reflux going on? Anytime I hear that there's more coughing with solids versus liquids, I'm at least suspect and would want to rule out reflux or something going on lower in the system, with the, like how you said, with the indigestion or things like that, that might just be kind of popping up and then irritating and getting him coughing. So if it sounds like it's manageable, if it gets any worse, or if you guys want to do a little more investigating, I think seeing an ear, nose, and throat doctor would maybe be the next best step.
Right now, you know, maybe once a day.
I don't think she could hear. He said he coughs once or twice a day, but he generally, yeah, but he does cough. He has the Lewy body with the Parkinson, and so his memory, but he does cough, but not. We're managing the cough now, but we do see, we have seen an eye, nose, and throat doctor, but he has nosebleeds, and so if we could go to him for that too. So I think that's a good suggestion. Thank you.
Yeah, no problem.
Thanks, Frida.
I always tell people too, I mean, it's never going to be a perfect fix. So I'm also of the mind, if it's not broke, don't fix it. I often tell people, if you're managing okay, you know, sometimes going down a path of doing all this extra assessment and intervention can cause extra, you know, additional issues. But so I think it really is managing risk and figuring out what kind of where you're at and what you can tolerate. I think if it's impacting you, if it's impacting your nutrition, if it's bothersome, if it's affecting your ability to go and socialize, or you know, anything like that, then it's worth getting it checked out.
Ashley, we got along the same lines, we got a comment from Laura that her husband coughs at night when he reclines to sleep. Any thoughts on that?
Yeah, so without knowing too much of the, you know, the history, in addition to that, I do think anytime, again, I'm hearing that coughing at night, I think can be some issues with managing just your own secretions, or it might be a little bit of some reflux. Anytime I hear coughing at night, that's one of the first things I want to rule out or address, is just make sure that there's not some reflux. And again, there's a type of reflux called LPR. It's called laryngopharyngeal reflux. And it's just what we call silent reflux. It's where you don't feel any kind of typical reflux symptoms. It's just a little bit of enough popping up to irritate and cause like some coughing and some secretions and things like that. So that anytime I hear something like that, that's where I want to rule that out first.
Ashley, Carolyn asked, what's the name of the expiratory equipment you referred to?
Yeah, so what it's called is it's expiratory muscle strength training. The one that has the most research is called the EMST 150. So expiratory muscle strength trainer 150. They have their own website. I have no affiliation with them, but I use their devices probably the most, just because they are the most researched, and incidentally they were developed at the University of Florida, so go Gators. My own little plug today. But they can be very, very helpful. They're used in lots of different conditions, even extreme athletes and singers have used them, and it's again really good for building breath support. I typically don't recommend someone to try to use it without at least a few sessions of some training with someone who is really qualified and able to kind of look at your full medical picture, because there are some contraindications. Heart things and uncontrolled blood pressure can be some of them, but really the pressures you're generating with that device are more, honestly, they're not any more than what you would use to pick up a heavy box or use a bowel movement. So we're not like talking huge pressures, but they can be very helpful for just improving that respiratory support and coordination, for being able to cough, for being able to really activate your respiratory system for communication as well. Again,
thank you, Ashley. So we have a question from Raju, and he asked the question, won't the say tell if this was a nasal drip or something else? And is expectoration is the goal here?
So do you mean like, so when we say like say ah as long as you can and listen to the quality and length of your voice, is that what you're referencing for the say ah? Or you mean looking in the back of your mouth?
Go ahead
Go
and
ahead.
unmute there, Raju.
All right, and excuse me for that accent, but the first comment was regarding the fact that the patient, whenever he used to lie down, is when he start coughing. Yes, so I was thinking of maybe it's the nerve that gets irritated. Remember, for that, the one that we take antitussives for. So maybe that is the reason, and this is the time of the year, I suppose, in Cincinnati for everybody to get those postnasal drips. Also, seeing and throat will probably tell us whether there is an irritation. The tracks of irritation will run down throat, I suppose. I don't know.
Yeah, so
But
that's
yeah.
Oh yeah, go ahead.
Yeah. So that's what. And expectoration is the goal, was a separate thing. That was a very recent comment I made on your device. You said there is a device, and I was wondering whether this expectoration is the goal, because I often get a tickle in my throat, and I'll keep making that kind of thing. And what happens is that the tickle won't just catch. One of the what I do is I turn around and I allow my stomach for some time, things like that, and then suddenly in one of those efforts of doing it, it catches and then it clears up, and I get some kind of phlegm, and then I feel relieved. So is that what we are talking about here?
It can be. Yeah, those are really great questions. So looking in the throat just from the mouth, you're only seeing a very small amount of real estate. But yes, that's one of the things that an ear, nose, and throat doctor does, is they actually assess the entire throat. So I've seen people that, they're like, I've been to the doctor, they don't see any irritation back there. But then once the ear, nose, and throat doctor kind of looks, and not everybody's really the same or addresses the same things. I think sometimes seeing a laryngologist, so someone who specializes with the larynx. I know at UC, that's typically Dr. Friedman, Dr. Kothla, or Dr. Howell are the people we refer to, but there's some great ones at Mercy and some of the other systems as well. I'm just not as familiar with them. That they really are versed in how your vocal cords specifically are working and can be impacted by some of these things. But sometimes you might not see the irritation right there in that little real estate that you can see from your mouth. But then when we look down, there's parts around your vocal cords that might be irritated or inflamed. The other thing is, we know you can get some vocal bowing with age and with Parkinson's, just from disuse. So your vocal cords, we use them for talking, but it's also their primary physiological function is to protect your airway. Right. So they sit at the very top of your trachea for your airway, and they close when we cough, when we swallow. So sometimes if those are bowed, it's not really closing off that airway as well. So again, sometimes I've seen people who just in going to see an ear, nose, and throat doctor, if they're significantly bowed, they can do things to bring them more together. And that was more beneficial than anything I could have done. And so that's where I think it's important to, like we said, we are part of and function in a bigger overall team to make sure we're addressing all those things. And then to your other point, Raj, about the postnasal drip. Yes. So when you're laying down and that's the time that you're coughing, I'm always considering postnasal drip or the reflux. So either way, right? Because when you're laying down, things are coming, it's more easy for things to come back up. Gravity isn't working in your favor to keep things down. So the other thing is, even before, if someone doesn't want to see an ENT or they can't get in for a little bit, we'll say, sleep with your head elevated. Don't eat 45 minutes before bed. See if that affects your symptoms. Because often if it does, again, that's an easy fix. Avoid things that are high acid, like tomatoes and things like that. Excuse me, or only drink coffee first thing in the morning. right? Versus later in the evening. All those things are things that can kind of irritate reflux a little more.
Ashley, Vince and Barb asked, it's becoming harder for people to hear me. What's causing this?
Well, at its core, the Parkinsons, so there's a couple different things that can be contributing. We know for one, it makes all the movements smaller. So it makes the movements that you're making with your mouth to get the sounds out much smaller. So instead of talking like I'm talking right now, oftentimes those movements gets a lot smaller and mumbly, and then it's hard to understand people. So it's on one hand, right, those things get smaller and smaller, and you're harder to hear. And the other thing is, along those lines, that coordination between all the systems, your breathing might get smaller, or your core might get a little weaker. So you're not as able to use your respiratory support, those breaths, as well as you had been. Excuse me. So typically those are the primary things, is though the smaller movements, both in terms of your articulators, how things are moving in your mouth, your breathing. And then, as I said earlier, it's not uncommon to have a little bit of that, your vocal cords get a little bowed when we don't use them like we should, and maximally to the full amount that we can. And just with age, they can get a little bit bowed. And so that's where those programs like LSVT and Speak Out can really have some great exercises to increase your intensity and increase how well you can use your voice and get your sounds out and be heard.
Ashley, can you give us a little more detail behind LSVT and the Speak Out programs?
Yeah, so they're both structured protocols. LSVT has been around probably the longest. It was designed by Dr. Fox. She's actually has a whole institute now, and so that's the big and the loud. So, excuse me, Lee Silverman Voice Therapy is what it stands for. You can also find them online. It's typically a very structured protocol. So the big is the physical therapy. So they work on big movements, retraining your walking, your moving, that sort of thing, recalibrating. And then for the speech, it's really lots of vocal function exercises, respiratory exercises, working on projecting, getting your sounds out, doing thinking loud, using your voice and your sounds more effectively. They're both very intensive. So I always tell people they're a little bit like boot camp. So the LSVT, the way it should work is an hour-long session 4 times a week for 4 weeks. And then I think the Speak Out they both have similar principles. So excuse me, it's a little bit different in that they're not quite as intense on the how often you have to come, but the Speak Out program they have very similar exercises, really using your voice, working on using your respirations, recalibrating your system to be aware, because all those movements get smaller very frequently, people, the thing I hear the most is, I'm talking just fine. No one else can hear me. Everybody else needs to get their hearing checked, right? That is the thing I hear every time. And I always laugh because when someone comes in and tells me that, I'm like, you are not the first person to tell me that. And sometimes it's true. Don't get me wrong. So there has been probably 2 people in the last year that their loved one came in, and then I tested them, and I'm like, their volume is actually okay. You do probably need to get your hearing checked. But by and large, 9 out of 10 people, it's that because you know what you're saying, and because that change happens so slowly, and because with Parkinson's, that ability to kind of self-monitor and regulate gets a little off. It feels normal to you, but you have to use a lot more effort to do those bigger movements. And so that's where both of those programs are retraining and recalibrating that effort to help you be able to use it better.
And Ashley, I would point out to everybody that there are, much like you, there are a number of therapists in our area
Absolutely.
that work with folks with Parkinson's, and we try and list a number of those on our website. So if anyone is interested in finding out about what's available, you can go to our website.
Wonderful.
It's under our moving tab and exercise, because they are in many instances exercise programs for the vocal cords and for your throat and mouth. We have some other interesting things around that's also support singing for Parkinson's.
Yes, I'm glad you mentioned that.
There's at least one group, and I believe there's a second group getting ready to start in Southeast Indiana, over in the Aurora neighborhoods. So I would suggest that folks might want to take a look at parkinsoncincinnati.org and look under our moving and exercise tabs for listings.
Singing is great. That's another one I always tell people is, if you're a singer, sing, keep singing, talking, read out loud when you read the paper. So things where you just use it or lose it, right? Continue to use that voice, continue to really work on being heard. And then the singing is great. And I think as who was it that was saying earlier? Was it you, Frida, about just the world we live in these days? I think one of the silver linings is that Zoom and these online things have opened up the ability to participate in a lot more things. So LSVT and even Speak Out is the other program we were talking about. They're designed by the Parkinson's Voice Project. They have a lot of resources on their websites, and they also have groups that you can join and participate in on there. And both of these programs also have a piece where you join a group after you're done, where you just keep using it, right? So you keep doing exercises, you have a group of like-minded people that you can talk with, and really the goal is just to continue to use the skill that you've built during the protocol.
Raju asked, when should one start a program like that?
I think as soon as you notice an issue, I think, again, it's easier to maintain and improve versus get it back. So I think the moment you start to feel like people are saying or asking you to repeat, if you're noticing or your loved one is noticing changes in your voice, start it then.
If we don't have any other questions, I'll go ahead and thank Ashley for a really informative program. And this is an issue that strikes an awful lot of our constituents. So it's an important one, and this has been very informing. I really appreciate it.